Right. Good afternoon, guys. I hope guys are okay. Welcome back to the bootcamp series with mocks. Without further ado, let's start. Right. So I'm sure most of you know me. For those who don't, my name's Smith. I'm a cardiac surgery registrar in London. At the same time, I'm finishing my PhD at the Imperial College London soon. Well, hopefully very soon. So I'll be a mock examiner today. As usual, we're going to do 2 stations. For each station, we're going to do the 10 minutes, like in the real exam. So I'm going to show you a candidate instructions for the first minute. You're going to read it. Then once the bell rings, we'll do the station for the remaining 9 minutes. If it's a skill station, then at the 6-minute bell, you have to stop, and then I'll ask you follow-up questions for the remaining 3 minutes. If it's a knowledge station, then we'll just continue to crack on. Regardless, you will hear a 6-minute bell. Right. So just receive the station, so we're gonna have fun. Right, great. So if you would like to do the station, I would need 2 volunteers, obviously. Just type something in the you can raise your hands, or you can type something in the chat as well. Great. So great. So well, Shafaf will do the first station. And then Singda, can you unmute your mic? And then you can confirm you can talk. Sorry, Snigda.
Yes.
Right, Becca, I'm really sorry. I'm not very good with the name. So if I mispronounce your name, I do apologize for that.
No problem. Snigdha.
Snigda, great. So you'll do the second station. Thank you for volunteering. So I've changed the system in a way that if you raise your hands first or type in the chat first, you will do the station. Right, first come, first serve. So that's it. So thank you very much for the other volunteers. Hopefully we'll be able to do the mocks next week. As you all know, this is our website, mastersbootcamp.com, and then Telegrams and WhatsApp groups. We've got these, and obviously you're in these, where we send out notifications, announcements, as well as the mock links. And then we've got a Facebook page, which is kind of like extension of the website, and then Facebook group, where if you've got any questions, you can go join it and then ask the question in the group. I will answer all the questions in that group. So, as I said, we are going to do 2 stations. So the first station will be done by Shafaf. So can you, first of all, I'm going to mute all of you. This is just to avoid the interruptions while we're doing the station. So Shafaf, can you mute your mic and then confirm you can talk?
Yes.
All right, great. Thank you. Before we proceed, please do not mute your mic because you won't be able to unmute on your own. So I'm going to set the timer. Are you ready?
Yes.
There you go. Can you tell me the boundaries of the femoral triangle?
Femoral triangle is bounded medially by the adductor longus, laterally by the sartorius, and superiorly by the inguinal ligament.
And what are the contents of the femoral triangle?
Femoral nerve, femoral artery, femoral vein, and femoral branch of genitofemoral nerve, and the femoral canal.
Anything else?
Lymph nodes of Cloquet.
All right. Is there only one lymph node in the femoral triangle?
Deep inguinal lymph nodes.
What structures could be injured by this cut?
10 centimeter below and parallel to inguinal ligament. So it will be the femoral nerve, the femoral artery, femoral vein, or the great saphenous vein as well.
Anything else?
And the muscles, the sartorius, the quadriceps femoris.
Right. What is this?
Sartorius, the femoral artery, common femoral artery, femoral vein, great saphenous vein, inguinal ligament, femoral nerve.
Right. So what does this supply in terms of the motor? What does the femoral nerve supply?
Femoral nerve supplies the flexors of the hip, iliacus and psoas, as well as the anterior compartment of the thigh muscles.
Such as?
The quadriceps femoris, which includes vastus lateralis, vastus intermedialis, vastus medialis, and rectus femoris.
What is femoral sheath?
Femoral sheath it's a continuation of the anterior abdominal wall fascia, which covers the femoral vessels, the femoral artery and femoral vein, and the femoral canal also.
Right. And which nerve is inside the femoral sheath?
There's a femoral branch of genitofemoral nerve.
What is femoral canal and what does it contain?
Femoral canal is a potential space just medial to the femoral vein, and it contains just the lymphatics and the lymphatic vessels, the Cloquet's nodes also.
What are the boundaries of the femoral canal?
Femoral canal is bounded medially by the lacunar ligament, laterally by the femoral vein, anteriorly the inguinal ligament, and posteriorly by the pectineal ligament.
What's the purpose of the empty space in the femoral canal?
It allows for the expansion of the femoral vein when there is increased venous return.
Is there any other reason why would the femoral vein be so distended, in addition to the increased venous return?
When the volume increases in the body, the circulating volume increases.
Increased venous return. Anything else?
I'll come back to it later, sir.
So, can you describe the anatomy of the saphenous nerve?
Saphenous nerve originates from the femoral nerve, and it passes the middle side of the thigh, and it passes under the adductor canal to come out in the middle side of the leg, and supplies the up to the foot itself, up to the first metatarsalophalangeal joint.
Right. And does it contain the big toe?
It does not supply the big toe, just before the base of big toe.
What is adductor canal?
Adductor canal is a potential space under the sartorius from the apex of the femoral triangle up to the adductor hiatus, through which the femoral artery and vein passes from anterior to the posterior side.
What are the boundaries?
Adductor canal is boundaries. Anteromedially, it is sartorius. Anterolaterally, it is vastus medialis. Posteriorly, there is adductor longus and magnus.
Which structures enter the adductor canal and which structures exit the adductor canal?
Structures entering are the superficial femoral artery, superficial femoral vein, nerve to vastus medialis, and the saphenous nerve. Among this, the nerve to vastus medialis does not exit. Other three.
Right. So what structures exit the adductor canal?
While exiting, it is like a popliteal artery, popliteal vein, and the saphenous nerve.
Great. So I think your 6-minute class just came up. So you've got 3 minutes. Got this. I'm going to stop the clock. So very well done. The only thing that you couldn't answer is it's a minor thing and it's not very important, but got this. When you said distension of the femoral vein is, you said, most of the time caused by the increased venous return / increase in the intravascular volume. What else causes the distension of the femoral vein? Right, before I forget, I'm just going to unmute all of you. Feel free to unmute your mic and then jump in the discussion as we go. Don't worry, we'll talk about it later. Go on.
Increase intra-abdominal pressure.
Very good. Increase in the intra-abdominal pressure. Right. If there is something blockage or compressing directly, or any increase in the intra-abdominal pressure can cause the distension of the femoral vein distally as well. Great. So well done. This is a very good performance. So Dr. Shafaf, very well done for this. We'll go through this station together now. So so this is the only picture, so we'll have a look at it. What is this?
Tensor fascia lata.
Tensor fascia lata.
Tensor fascia lata.
Sartorius.
Sartorius.
Inguinal ligament runs
Inguinal
from
ligament.
where?
Anterior superior spine to pubic tubercle.
Pubic tubercle. Very good. And this one?
Femoral vein.
Femoral way.
Long
Greater saphenous vein.
So great saphenous vein or the long saphenous vein, depending on how you call it. Don't mix and match.
Femoral artery.
Common femoral
This is
artery.
superficial femoral artery.
Yeah, this is the
Common femoral.
Femoral
Vein, nerve.
Femoral nerve.
the
Femoral
profunda.
branches.
Deep femoral artery.
Deep femoral artery.
Femoral artery.
Or femoral profunda, right? Profundus artery as well. That's pretty much of it. So what we're going to do is just going to load up the portal, and hopefully you guys can see it as well. So let's go to the notes. 2 of 5, I think. Great. So we're going to start with the description of the femoral triangle. So tell me the boundaries of the femoral triangle.
Laterally sartorius, superiorly inguinal ligament, and medially adductor longus muscle.
Very good. The roof.
Roof superficial fascia of the thigh.
Fascia lata. In the
Fascia lata.
skin and subcutaneous tissue.
Very good. Fascia lata, skin and subcutaneous tissue. How about the floor?
Iliopsoas and pectineus.
Iliopsoas, pectineus.
Great. So
And adductor
iliopsoas
longus.
and pectineus laterally and adductor longus. It's not usually described as a floor, but yes, if you go deeper than that, adductor longus will be there as well. What's inside the femoral triangle?
Femoral vein, femoral artery, femoral inguinal lymph node,
And deep inguinal lymph nodes. Don't forget the deep inguinal lymph nodes, right? Of course, we know the artery, vein, and the nerve spot. Great. So the boundaries superiorly is the inguinal ligament. We're going to have a look at the picture now. So this is a superior border. This is a lateral, and this is the medial. And these are the structures. Well, we'll talk about briefly in a minute. So superiorly is the inguinal ligament running from ESIs and your superior iliac spine to the pubic tubercle. By the way, what is this?
Lateral cutaneous nerve.
Lateral femoral cutaneous nerve. And if it's got entrapped here, what will happen?
Neuralgia.
Neuralgia paresthetica. Great. Again, I would like to go into the details of neuralgia paresthetica, but I'm going to stop here. Right. Medial is the adductor longus. You can see here. And laterally is the sartorius and the roof fascia lata, subcutaneous fat and skin. The floor is iliopsoas and pectineus vein. The content, femoral artery, nerve, vein, and deep inguinal lymph nodes, as you can see. So this is the femoral triangle. Right, inside the femoral triangle, there are important structures, as we can see. The apex of the femoral triangle is the start of
Adductor canal.
Adductor canal.
very good adductor canal. That's where the adductor canal starts, and then at the tubercle the adductor longus to adductor tubercle, that's where the adductor canal stops, right? So we'll talk about this one because if we notice femoral vessels are anteriorly in the groin, and at the knee, the popliteal vessels, they became popliteal vessels, they are posteriorly. How come? Because they pass through the adductor canal from anterior to posterior, right? So the next is if there is a cut, right, like this one about 10 centimeters below and parallel to the inguinal ligament, what structures could be injured?
Everything within the canal.
Superficial femoral artery.
Sartorius.
So there are a lot of structures that could be injured, but your answer must be systematic. So we can say, let's say, we can talk about arteries, we can talk about veins, talk about nerves, and we can talk about muscles. Tell me, which arteries could be injured?
Femoral artery.
Mainly
Femur-
superficial femoral
Superficial
artery.
femoral
I
artery.
would have given up the deep profunda femoris. So it would be superficial femoral artery, and then sometimes circumflex, especially the lateral circumflex artery could be injured as well. Right, mainly superficial femoral artery. The vein.
Femoral vein.
Great
Mhm.
saphenous
Saphenous
vein,
vein.
femoral
Greater
vein.
And
saphenous
don't
vein.
forget the great saphenous vein, because around that area, slightly, although it's a little bit lower, that level, just above that one, there will be SFG junction, which is saphenofemoral junction, great saphenous vein draining into the femoral vein directly. Nerves.
Femoral nerve.
Femoral
Femoral
nerve.
nerve.
Any other nerves?
Femoral branch of genitofemoral.
Very good. That is particularly important because that nerve, small nerve, lies inside the
Femoral triangle.
Femoral sheath.
Femoral triangle.
femoral sheath. All these structures lies inside the femoral triangle, but femoral nerve is not inside the femoral sheath, except
Yes.
the femoral branch of the genital
The
femoral
nerve
nerve
branch.
inside the sheath. Right. Great. And then which muscles?
Sartorius.
Sartorius.
Adductor
Adductor longus.
longus.
Dr. Longus could be quite deep, right? The cut must be really deep, but yes, could be injured as well. But tell me what's beneath the sartorius? Big bulk.
Iliopsoas.
Iliopsoas.
Artery
Pectineus.
cells.
Rectus femoris and the
Rectus
vastus.
femoris.
Quadriceps.
Vastus lateralis,
Quadriceps,
vastus
meaning there are 4
intermedius,
muscles. So
vastus-
rectus femoris.
vastus lateralis, vastus intermedius, vastus
Terminals.
medialis.
Very good. There are 3 vastus muscles, and on top of that one, there is rectus femoris. Right. So if you look at this one, this would be
Rectus.
Rectus femoral.
rectus
Rectus
femoris.
femoris.
Vastus
Vastus
medialis.
Medialis.
Vastus
Lateralis.
Lateralis.
Great. And so let's talk about the femoral sheath now. So if you notice it, these 3 structures, especially this one's more visible. So these 3 structures will be wrapped around in a sheath called femoral sheath. So let's start with what is femoral sheath.
Prolongations of the abdominal fascia,
Great.
anteriorly transversally fascia, posteriorly by iliopsoas fascia.
So it's abdominal fascia, prolongation of the abdominal fascia, and wrapping around these things. What's inside the femoral sheath?
Femoral
Everything
artery.
is
Femoral
artery,
nerve.
femoral
Femoral
vein.
nerve.
Branch of genitofemoral nerve.
Right. So if you look around it, this is the wrapping around the femoral sheath, and there's a small nerve as well. Please note, again, this is a very common point for the candidates to get confused. Femoral nerve is outside the femoral
Not.
sheath. Downward prolongation of the abdominal fascia into the femoral triangle, mostly is the transversalis fascia anteriorly and iliac fascia posteriorly. But it does not contain femoral nerve. That's very, very important. Next, the femoral canal. What is femoral canal?
The medial compartment of the femoral sheath.
What's inside it?
Lymph node of
Just
Clockway.
Pretty much nothing
fat
except,
connective tissue.
Vessels.
except the lymph node, which
Node of
is usually
Deep inguinal lymph node.
termed as Cloacase lymph node. But Cloacase lymph node is significant because it usually acts as a sentinel lymph node, the most superficial node of the deep inguinal lymph node group. So great. Apart from the lymph nodes, nothing's much there. Why is there empty space?
To allow distension of the venous compartment.
Great. If there is a distension of the nearby vessels, there must be a bit more space. Otherwise, they won't be able to expand. So that's why femoral canal is there. and femoral canal is the most medial compartment in the femoral sheath. Right?
Sheath.
And it's approximately about 1.3 centimeters long. It contains the lymphatic vessels and the lymph nodes. And the cloacace lymph node is usually described as the one, which is the most superficial node of the deep inguinal group. Medial lacunar ligament. I've got to ask you the boundaries, but anyway, let's go through this. Medially lacunar ligament, laterally would be obviously femoral vein, and then inguinal ligament anteriorly, posterior pectineal ligament, and the pectineus muscle. So these three things are quite confusing when you start revising anatomy, especially femoral triangle, femoral sheath, and the femoral canal. So that's why you need to carefully look at it. This is the femoral triangle. And the wrapping around this three structure is the femoral sheath. Inside the femoral sheath, the most medial compartment is the femoral canal. So I hope that's made things very clear. So we will talk about adductor canal. So before we talk about the adductor canal, so let's talk about adductor canals as well. So tell me what's an adductor canal.
Adductor canal is also known as a subsartorial canal or the Hunter canal. It extends from the apex of the femoral triangle to the adductor tubercle, popliteal.
So four things go in, but only three came out. Why?
Because this
intermediaris nerve.
So let's start with the boundaries of the adductor canal. So tell me the boundaries of the adductor canal.
superiorly it is bounded by the sartorius muscle.
Sartorius.
It is bounded by the vastus medialis muscle, and posteriorly bounded by the adductor longus and
adductor magnus.
It's a canal kind of like in a triangular shape. So how we can describe it is posteriorly always the adductors, longus and the magnus, and anterolaterally and anteromedially. Anteromedially, if you notice, sartorius starts from what's the
Anterior superior leg spine.
Anterior superior leg spine.
Anterior superior leg spine, and then goes towards the medial side of the knee. So it's towards the end of the adductor canal. It crosses over to the medial side. So that's why it forms the anteromedial aspect of the adductor canal. Whereas the vastus medialis would form the anterolateral.
Anterolateral.
So four things go in. Superficial femoral artery and vein, saphenous nerve, which is the continuation of
Femoral nerve.
Femoral nerve.
very good. Saphenous nerve is the continuation
No,
of the
it's a
continuation of the femoral nerve. So femoral nerve continues as the saphenous nerve, and then the fourth structure is the nerve to vastus medialis. Obviously, the nerve to vastus medialis goes to the muscle, stays inside the canal. That's it. Only three things came out, which is once out of the canal, it's called popliteal artery, popliteal vein, and saphenous nerve. Right. Adductor canal. It's also called Hunter's canal because it's named after John Hunter. And guess what? I work at this very same hospital where John Hunter works. John Hunter, I believe he is a Scottish surgeon. I even saw some of the manuscript written by Hunter and other famous people that worked inside the hospital. So guess how old is my hospital? If you know it, you're not allowed to say it, all right? This is for new people. All right, just give it a guess. How many years old is my hospital?
400.
And hint, this is the oldest hospital in England.
Oh, then it must be the 1,000 years old.
800.
1,000, that's a big show.
800 years.
500, okay. Anyone say 200?
800.
So the correct answer is
1,123, I think.
Yes, that's correct. So 1123 was when it was founded. So we celebrated
1123
back in 2023. So that was a big ceremony. So it's a 900 years old hospital, St. Bartholomew's Hospital. Currently, we are the biggest heart center in Europe, and a very, very good cancer center as well. So a few of the people who worked at this hospital, William Harvey, who discovered the circulation, right? And then Hunter, and then you would probably know that person who is regarded as the father of the modern orthopedic surgery, and he is Percival Pott. Right, we still have a ward named after him. so peripheral ports. And if you notice, again, if you read Sherlock Holmes and if you like Sherlock Holmes, Dr. Watson met Sherlock Holmes at Bart's Hospital Pathology Laboratory because Sir Arthur Conan Doyle, who is the author of the Sherlock Holmes, worked at the same hospital as well. Well, I could go on, but enough of that. So coming back to here, so Hunter's Canal. So it's a trough-shaped intermuscular canal occupying the distal 2/3 of the medial aspect of the thigh. So it starts at the apex of the femoral triangle and extends distally towards the adductor tubercle. And then the boundaries, anteromedial, sartorius, anterolaterally is the vastus medialis. As you can see here, this is the vastus medialis. And this is the nerve to the vastus medialis. And then this is, what would this be?
Saphenous nerve.
Right, this is a saphenous nerve. And these are the femoral vessels coming out and then becoming popliteal artery, the vein. So 4 structures goes in, but only 3 came out because this goes to the muscle itself. Right. So let's have a look at the popliteal angiogram anyway. So what happens after the popliteal artery comes out of the adductor canal and then passes through the popliteal fossa? What happens next?
Divide
And
into
it divides
2
into
branches.
Divides into 2.
tibioperineal.
Anterior tibia and tibioperoneal tract.
Great, anterior tibial artery and tibioperoneal trunk. Which
Tibioperoneal trunk.
into
Posterior tibia artery.
Posterior
Peroneal. Peroneal.
Peroneal.
posterior tibial artery and the peroneal or fibular artery.
Fibular
however you
artery.
call it. So we are going to have a quick look at pictures. So this is the right, this is the left, obviously. So let's start this one. So this is the superficial femoral artery coming out of the adductor and becoming popliteal artery. Popliteal artery initially divides into 2. So this would be,
Anterior
Anterior
Anterior tibia
tibial
artery.
artery.
and then continues as the tibioperoneal trunk and then further divides
Tibioperineal.
into 2.
Posterior
Posterior
tibial and
tibia.
Posterior
fibular.
tibial and fibular artery.
Which one's fibular, which one's posterior tibial?
Lateral.
The one that's
side
going
Lateral is
medially
fibula.
is the
Fibular.
The one that
posterior.
goes medially is the posterior tibial because, well, as you all know, when you're going to
Fibular is the lateral one.
posterior tibial, it's behind the medial malleolus, right? So the other one goes towards the lateral malleolus and supplies the lateral compartment. Great. So this is a brief overview of the popliteal angiogram as well. So this is the this is pretty much the end of the first station. Do you have any questions?
I wanted to ask about the site of auscultation for femoral bruit.
Okay. Sorry,
Because I
did you
read
ask a question
somewhere,
or you wanted to ask a question about femoral bruit?
yeah, the site for auscultation for femoral bruit. So I read somewhere that the adductor hiatus is where the superficial femoral artery passes through that place, and that's where the bruit may be auscultated. So is that where we listen for it, or is it in high up in the groin?
To be honest, you can listen anywhere along the artery to hear the bruit. Where you think the narrowing is. But classically, for the purpose of the exam, what they want you to know is the surface anatomy of the femoral artery.
Femoral artery.
How would you describe the surface anatomy of the femoral artery?
Midpoint
So
of
it would start from
the
the mid-inguinal
mid-inguinal
point.
point.
Mid-inguinal point or midpoint of the inguinal ligament? These are again
Mid-inguinal
very
point.
confusing.
Mid-inguinal. It's mid-inguinal point.
Mid-inguinal point.
Mid-inguinal point is the correct answer. But again, I've got a bit of stupid ways to remember things, but midpoint of inguinal ligament, meaning
It's a
the
deep
ligament
internal
has
ring.
something to do with the hernia. So that is the surface marking for the deep ring. Whereas the mid-inguinal point is the surface anatomy for the femoral
Femoral artery.
femoral artery. Again, it's a continuous with the external
Iliac artery.
Iliac.
It's the same many of the time in the body. It's the
Yeah.
same structure continuing, but
Just
it's
name
passing
different.
something and then the name changes. Right, same once it passes down the inguinal ligament, it becomes the common femoral artery. The external iliac becomes the common femoral, and then give rise to the profunda and then continuous superficial. And then once it exits the adductor canal again, it becomes a popliteal artery as well. So coming back to your question, I think for the purpose of the exam, it would be best if you listen the bruit on the mid-inguinal point.
Okay, thank you so much.
You're welcome. Any other questions?
Should we include the lateral femoral cutaneous nerve as a content of the femoral triangle?
Normally, it would be described as a superficial structure, not necessarily the content of the femoral triangle itself, because it's a very superficial nerve and it supplies the lateral part of the thigh. So it sometimes passes just over the sartorius, not necessarily inside the femoral triangle. So I wouldn't include it. Right. Great.
Femoral lymph nodes, are they making the roof or the content?
Say it again.
Superficial femoral lymph nodes are making the roof or the content of femoral triangle?
I would say the roof. I would include it in the roof because they are very superficial. As I said, only the deep inguinal lymph nodes would be characterized as the content of a triangle.
Okay.
But again, if, well, you, depending on the context, what the examiner wants, you can change the answer a little bit. Nobody can say it's wrong because you included the superficial inguinal lymph nodes in the femoral triangle. Right, so let's move on to the second stage. All right, before we move on, well, we offer the subscriptions, as you all know, so please do feel free to come and join us. We discuss every individual stations like this. Right, and if you're interested, come and join us. And one more thing is, I've been told there are only two seats left, I think, 2 or 3 seats left anyway. So this is the London on-site course for the May exams, and we're going to do it towards the end of April. If you're interested, the venue is now confirmed to be the usual venue, which is the London Marriott and Kensington Hotel. So please feel free to come and join us. Once the seats are filled, there's nothing you can do. I often struggle with that problem because I limit the number of the candidates because I want to control the quality of the course. And we do certain things where the number is if the number is very large, then we can't really do it. So the number is limited to 15. Or maximum 14 to 16, right? Depending on the context of the course, but the number will not be more than that. So I think there are 2-3 seats left. If you're interested, please come and join us in London. Great. So the next would be Dr. Snigdha. So I'm going to mute all of you again. Towards the end of the session, I will let you unmute it. So I'm going to ask now Snigdha to unmute your mic and confirm you can talk.
Yes, yes.
All right, great. I'm going to set the timer. Are you ready?
Yes, sir.
There you go.
Yes.
Right. Can you tell me your differential diagnosis?
Yeah, it would be diffuse simple diffuse goiter.
Give me a few other differentials.
Yeah, toxic nodular goiter, single toxic nodular goiter, multinodular goiter, thyroid neoplasm.
Give me differentials out of the thyroids.
Okay. Next one.
Any other differentials that could be not thyroid related?
Thyroglossal cyst.
Okay. Anything else?
Sorry, I cannot.
Can you describe the thyroid hormone excess?
From the hypothalamus, hypothalamus release thyroidopin releasing hormone, which stimulate the anterior pituitary gland, which release thyroid stimulating hormone, which stimulate the thyroid gland to produce thyroid hormone T3, T4.
Anything else?
And it works at the peripheral different tissues. And if the hormone level increases, then it gives negative feedback to the anterior pituitary and also the hypothalamus.
Can you describe 6 features of hypothyroidism? 6 of them,
Yeah.
any 6.
Mental retardation, hair loss, and obesity, myxedema, then constipation, bradycardia.
Can you tell me 3 causes of hypothyroidism?
It could be primary or secondary. Primary causes Hashimoto thyroiditis, iatrogenic like some drugs, carbamazepine, or radioactive iodine, or surgery, and it could be some depositions like amyloidosis, sarcoidosis, and it could be due to nutritional deficiencies, iodine deficiency, and secondary cause may be pituitary or hypothalamus problem.
If the cause is central hypothyroidism, what would be the picture of the thyroid function test?
The thyroid hormone will be decreased and the thyroid stimulating hormone will be increased.
If the thyroid, if the hypothyroid patient who is not very compliant with the medications, he presented for emergency surgery, what would be a concern?
Okay, preoperatively, I will be concerned about anemia, ischemic heart disease. Intraoperatively, I will be concerned
Tell
about
me one.
bradycardia. Yeah.
Tell me one, and a very severe one, in fact.
Okay.
Patient is
Cardiac,
not taking medications regularly, presents for
yeah,
emergency surgery.
yeah, hypothermia or cardiac arrhythmia.
Anything else?
Ischemic heart disease.
All right. So your boss is worried about, sorry, myxedema coma. So tell me, what is myxedema coma?
I don't know the definition actually.
How would you improve the compliance of the medications by the patient?
Yeah, I can make it a single dose, and patient may take it at morning, and I may involve family member or caretaker to monitor his or her medication at the time of taking medications, and I will inform them properly that if you don't take medication, there is there is chance of relapse, and it will be very harmful for him or her.
Later on, the blood shows the patient's having anemia, but macrocytic anemia. What would be the cause in this patient?
It could be antiparietal cell antibody present, and it prevents, and there will be absence of intrinsic factor. That's why less vitamin B12 deficiency, and there will be vitamin B12 deficiency, and it will cause macrocytosis and pernicious anemia.
Right. So what is the likely cause of hypothyroidism in this case?
60 years old. Yeah.
What are the indications for surgery in hypothyroidism?
If it's have compressive features or any a cosmetic purpose or any chance of malignancy, then we can go for surgery.
What are the complications of hypothyroidism?
It may hypothyroidism. Complications are hypothermia and bradycardia, hypotension, myxedema, coma.
Whom would you like to involve before surgery if this patient is going for surgery?
Yeah, I will involve my consultant, anesthetist, endocrinologist.
Normally, when would we do surgery on a hypothyroid patient?
Myxedema, coma.
No, the questions, let me re-ask you ask you the question again. When would we do surgery on a hypothyroid patient?
Sorry, I don't know.
And in this case, let's say the emergency, what else are you going to do if the hypothyroid patient's going into surgery?
Okay, I will manage the patient according to CRIS protocol, and I will give leothyronine injection and hydrocortisone. I will start a high dose steroid.
Why would you give leothyronine?
Because patient has patient don't have enough thyroid hormone, and I have to give the active form. That's why.
All right. So have you ever heard of sign of Hartog?
What?
Sign of Hartog. Hertoghe.
Okay, I don't know.
What are the complications of thyroid surgery?
It may cause recurrent laryngeal nerve injury, hypocalcemia, and
All right, time's up.
Okay, patient need thyroxine lifelong.
All right. I'm not sure why you said patient need thyroxine lifelong, because we're talking about complications of thyroid surgery. All right. Anyway,
Okay, sorry.
great. Anyway, so before I forget, I'm going to mute all of you, and I'm going to enable chat as well. So the reason I disable the chat is because somebody's typing the answer. But it's very easy for you to relax and then sit back and then think about these answers versus if you're put in the hot seat under pressure. These are very much different, right? So I'm going to give a brief individual feedback to Sneakta first. So the next running with months of Malay. So you talk about all the thyroid, obviously differentials, but you need to give me some of the differentials outside the thyroid as well, which we'll talk about it later. And then myxedema, coma, obviously you can tell me the definition. So I'm sure many of the things, one of the simplest things that you can test yourself is if you can explain complex things in one single sentence, then you understand that concepts quite well. If you cannot, well, most of us, we have been in that situation, for example, oh, I know that, but I don't know how to explain this one, because you don't really understand the concepts down to the core. That's why. So it's very important for you to able to describe it in a short sentence. You can use that to test yourself in different areas all the time as well. Right. And then the likely cause of the hypothyroidism, we'll talk about that later on. And what are we going to do with the emergency surgery? We don't always give leothyronine, by the way. We'll talk about that, and the sign of Hertog. So maybe I'm pronouncing wrong, so I spell it out for you as well. And then two more questions that you can answer. One is the complications of thyroid surgery, and the other one is choose one complication and manage it. So these are very common questions for the thyroid stations. So why don't we go through this station together? So this is a 60-year-old gentleman, lady, referred by her general practitioner with enlarged neck swelling with Malay for months. Past medical history includes diabetes, hypertension, and rheumatoid arthritis. Right, rheumatoid arthritis is an autoimmune disease. So you have to keep that in mind. So I'm going to do is I'm going to share you the portal. It's a critical care station. So let's quickly talk about these one by one. So let's start with the thyroid hormone axis. So how would we describe the thyroid hormone axis?
So it starts with
From the
hypothalamus secreting
hypothalamus.
thyrotropin releasing hormone, which stimulates anterior pituitary to release thyroid stimulating hormone, which stimulates thyroid to form the thyroid hormones T3 and T4, which can exert negative feedback on both the pituitary gland and hypothalamus.
Great. And T3 or T4, which ones produce in large amounts?
T4.
T4 and T3 undergoes peripheral conversion.
Which one's the active form?
T3.
T3.
T3 is the more active form, and the body
T3.
don't want to cause a lot of problems. So that's why T4 is produced in large amount, and then they will undergo peripheral conversion, and then will be released into
T3.
where they really need it. Well, great. And then do not forget about the negative feedback. Very, very important for the thyroid hormone axis. So hypothalamus produces TRH, which is thyrotropin releasing hormone. Anterior pituitary gland will produce TSH in response, and the thyroid gland will produce T3, T4, and negative feedback to both anterior pituitary as well as the hypothalamus to produce these TRH and the TSH as well. Before we forget, what would be the differentials for this case? Give me a
Apart
few
from the
Lymphoma.
differentials he mentioned, it should be tuberculosis, lymphoma, enlarged lymph node.
Enlarged lymph nodes.
What kind of lymphoma?
It could be
Hodgkin's
infective like
lymphoma.
tuberculosis.
Hodgkin's
It could
and
be
non-Hodgkin's.
lymphoma.
Hodgkin's.
lymphoma.
Hodgkin's.
I would go with the Hodgkin's. Why?
Midline.
Age
Axial
group
lymph
60
node.
years and
Age
neck
group and
cervical.
the neck cervical lymph node in normal.
So cervical lymph nodes at the age of 60, because Hodgkin lymphoma has got two age peaks, around 20-25s and around 60-65. So there are two peaks very common with the cervical lymph node. Obviously, we need to take a sample and then see to say this is Hodgkin lymphoma. So what do you need to see?
Reed-Sternberg
Steinberg
cells.
cells.
Reed-Sternberg cells. What are Reed-Sternberg cells?
Giant
These are
cells, which are
large
bilobed.
cells with bilobed nuclei.
Binuclear
What type of
B
cells are
cells.
these?
Binuclear B cells.
B
Giant
cells.
cell.
They are derived
B
from the B cells. Great. So that's a quick touch on the Hodgkin's lymphoma as well. So don't forget about the malignancies, tuberculosis, and the lymphomas as the extra thyroid differentials. And then you can throw in so many thyroid things here. Right. Next, tell me at least 6 features of hypothyroidism.
Weight gain, memory loss, depression, menorrhagia, constipation, cold intolerance, bradycardia.
Great.
Dry and coarse
So
skin.
hypothyroidism and hyperthyroidism are usually opposite to each other. And in hypothyroidism, everything will go down except the two.
Weight
Menorrhagia and
gain.
weight gain.
Menses and the weight gain. So menorrhagia and the weight gain. And the vice versa is true in hyperthyroidism. Everything will go up except that too. Again, that would be
This
Irritability, hot intolerance, diarrhea,
weight loss and
weight loss and
increased
Menorrhea.
appetite.
menorrhea. Apart from that one, everything will go up, meaning sweating, anxiety. For example, if we're talking about the mood, it will be anxiety rather than the depression and such. So make sure you know at least 6 of both hyper and hypothyroidism symptoms. I'll list a few. So intolerance to cold, weight gain, dry coarse skin, depression, constipation, vice versa. The other one will be diarrhea, hypothermia, menorrhagia in females, bradycardia, hypertension, fatigue, lethargy, etc. Give me what is the most common cause of hypothyroidism?
iodine deficiency.
Autoimmune.
Hashimoto's
Autoimmune.
thyroiditis.
Iodine deficiency.
So overall, it is iodine deficiency. But in developed countries, we iodinate salts. So we don't have iodine deficiency anymore. And in fact, most of the majority of the world were going towards that move as well. So in the Western countries, Hashimoto's is the most common. Tell me a few other causes of hypothyroidism.
Drugs, CPS.
Iatrogenic.
Lithium amidro. Thyroid, viral thyroiditis. and post-thyroid
Infiltrative
surgery.
causes like amyloidosis or choroidosis.
Great. So there are so many. Common ones are iron deficiency and Hashimoto's. These are the most common ones. And the drugs like lithium, very famously used in psychiatric disorders, cause this one. And amiodarone, as cardiac surgeons, we love amiodarone. Right? Thyroiditis and the post-thyroid surgeries, as well as the post-radioiodine treatment as well. Now the patient comes
And
to you.
idiopathic.
And yeah, so if we can't find it, we just put the idiopathic. So if the patient comes to you who is not very compliant with the medications and the patient needs to undergo emergency surgery, what would be a concern?
Myxedema coma.
Myxedema coma.
What is myxedema coma?
It is
It's
a
a
ultimate
severe
state of
form of
the
hypothyroidism.
hypothyroidism.
So this is the last stop before death. Whatever the hypothyroidism symptoms there, the most severe forms will be depicted here. Meaning, if something happens, let's say hypertension, profound hypertension will be here. Hypothermia, profound hypothermia, very severe hypothermia.
Respiratory depression.
A lot of these, and this will lead to organ dysfunctions, multi-organ failure, ultimately coma. If you don't treat it, will be the next death. So that's why this is the ultimate state of hypothyroidism before death. You have to aggressively treat it. Hypothermia, hyporeflex, hypoglycemia, bradycardia, seizures, coma. And it could be triggered by any of the stressful events on the body, by these severe infections or myocardial infarction, stroke, trauma, surgery, all the things that we talk about. Well, so this is myxedema coma. Next, patients found to have right, before we move on, how would we improve the compliance of the medications from the patient? Because this patient's not taking medications well.
Make it a single
Simplify
dose
the
to be
dose
taken in the
regime.
morning, involve the family
Simplify the
members and
dose regime.
regular
Educate
follow-up.
family members and alarm and apps and enroll in GP and and educate about the risk when we are not getting drugs properly.
Great.
Also, find out if patient is having a possible side effects that is discouraging him from taking the medication.
Right. Great. So we'll talk about these briefly in the management. Right. So let's continue. So the patient's found to have microcytic anemia. And what the cause, obviously, pernicious anemia should come to your mind because patient's got rheumatoid arthritis. Now the patient's probably having autoimmune thyroiditis, and that will usually go with the autoimmune pernicious anemia as well. So what is pernicious anemia?
Antibody produced
vitamin
to
B12 and folate
parietal
deficiency.
cells, and parietal cells not secrete intrinsic factor, which is important to absorb vitamin B12 in the terminal ileum and reduce vitamin B12 in the body, cause to microcytic anemia.
Great. So vitamin B12 deficiency will lead to folate, and vitamin B12 deficiency, in fact, will lead to macrocytic anemia, which we'll come back to that in a minute. Antibody to parietal cells or intrinsic factor or both can result in pernicious anemia because vitamin B12 in its own form cannot be absorbed directly into the body. It needs its carrier, which is the intrinsic factor. And then it will bind to the intrinsic factor all the way down, and then it will be absorbed in
Ileum.
Terminal ileum.
That's why, for
Terminal
example, terminal ileitis, Crohn's, they will lead to vitamin B12 deficiency, not because they don't have intrinsic factor, but because they can't really absorb it. But why would vitamin B12 or folate or both will lead to macrocytic anemia?
They are
help to
important
make
for
DNA
erythropoiesis.
DNA synthesis and due to reduced DNA synthesis and the cytoplasm get increased and cause to macrocytic anemia.
This is because vitamin B12
to-
is necessary for cell division. So
required for cell division.
The
Vitamin B12
RBC will keep growing and it will not divide, so it will be bigger during division or growth.
What's happened is vitamin B12 or folate is required for
DNA
synthesis. Cell cycle will not go from G2 to
if that's correct, so if the nucleus is not ready to divide yet, then it will keep growing. So that's why the cells are bigger if it divides. Even if it divides, for example, by the time it's ready to divide, not only the nucleus, but all the cytoplasm grows with the cell as well. So that's why By the time the nucleus is now taking much longer to synthesize the required DNA, 2 sets of DNA, and to divide. And by the time they're ready to divide, cytoplasm continues at its own rate, so the cells are very large. That is something called nuclear cytoplasmic asynchrony. And by the time they divide, if they divide, then the cells are much larger as well. So these are very important, especially the folate as well, very important for the pyrimidine synthesis. Next sign of Hartog, what is it?
It's the
It's
loss
the
of
loss of
lateral
lateral
eyebrow.
1/3 of the eyebrow.
It's a very weird sign. And Queen N has caught it as well. That's why sometimes
Yes,
referred to as Queen N's
Queen and
sign as well.
sign.
Loss of outer third of the eyebrow. And it's a very non-specific sign. Could be happening in hypothyroidism. Give me other conditions where it can happen.
Leprosy.
Leprosy.
Dermatitis.
Leprosy, atopic
That's a form of
dermatitis.
dermatitis, or even in leprosy as well.
Leprosy.
So it's all Queen's N sign, and it's loss of outer third of the eyebrows. Can be observed in hypothyroidism, dermatitis atopica, and leprosy. You can see these are really related things. Next, management. How would you manage hypothyroidism?
Replacement.
Replacement.
To know the cause first.
Thyroxine.
It's important to find out the cause, but many of the time, all you need to do is just replace it. That is levothyroxine.
Yeah.
So we can't really give thyroxine because thyroxine is a active form that's going to cause a lot of problems, especially to the gut. As you notice, if you remember, hyperthyroidism causes diarrhea and such. So if you give thyroxine directly to the gut, it's going to cause diarrhea and lots of problems, lots of side effects. So what we do is very simple. We rotate the chemical from D to L, meaning D is the right-handed molecule, convert it as a mirror image, that's the L, levothyroxine. The same thing we do with, let's say, local anesthetics, for example. Bupivacaine, very toxic to the heart. So what we do is, again, rotate it, and then we make a levobupivacaine, which is much less toxic to the heart than the original bupivacaine and such. And let's quickly have a look at it. So hormone replacement therapy and the increasing compliance, we just briefly talked about it, is the family. Very important. Sometimes what I usually joke is if an elderly man comes, if a couple comes in, all you need to tell is the wife. Right? If the man's a patient, and tell the wife, okay, you need to take this, and that's all you need to do. All right. Jokes aside. And then you need to include the GP. Support groups are available, especially for those who are struggling. And education about the dangers, very, very important. Untreated hypothyroidism can lead to loss of life. So the patient must really understand this one. So it's your job as a doctor to educate the patient as well. Simplify the regimen. Just don't make it twice a day, 3 times a day. Simplify it to once a day. That will tremendously increase the compliance. Alarms, reminders, and the latest, the mobile apps you can use. You can ask them to, and you can encourage them to use this to take the medications on time. Monitor the TSH. What are the indications for surgery in hypothyroidism?
Cosmetic
Evidence of
compression,
malignancy
cancer.
and the compression symptoms and the cosmetic reasons.
So one is the compression symptoms such as
Respiratory difficulty,
respiratory
dysphagia.
dysphagia, that is the
Hoarseness of voice.
compression of the esophagus, or compression of the
Dyspnea.
trachea causing the dyspnea and such, or cosmetic reasons very common in the younger populations.
Female.
And the females, that's correct, females as well, and suspicion of the malignancy. Sometimes, rare circumstances, when you take a biopsy, especially what biopsy do we take?
FNAC.
When you take the FNAC and sometimes it comes back follicular cells. So what do you tell the patient?
We don't know. We need to do a biopsy. It could be follicular adenoma, it could be follicular carcinoma.
So the thing is, that's correct. You can't really differentiate between the follicular adenoma from the follicular carcinoma from the FNAC alone. So what we have to do is take more sample. What are the types of biopsy? So FNAC is usually the first line. What's next?
Core biopsy.
Core biopsy.
Core biopsy.
Excisional biopsy.
Incisional biopsy.
Incisional biopsy, excisional biopsy, wet biopsy.
So what will be next for the thyroid?
Excisional biopsy.
Excisional. Remove the thyroid.
Usually incisional biopsy. We usually do lobectomy or subtotal thyroidectomy because what you don't want is remove everything. and then later on find out it's not cancer either.
Lumpectomy
So
and
what-
mastectomy.
why can't we do core biopsy?
Highly
Because if it's a
lots
carcinoma,
of
then there
vascular
is risk of
structures.
seedling.
The
of tumor.
thyroid is highly vascular. It carries a lot of risk with
Well, we
No, but
can
you can
do.
always do an ultrasound guided one. So
Well, let me tell you, if you say it's highly vascular, because we do, for example, kidney biopsy, core biopsy, we take a big chunk. It's much, much more vascular than the thyroid. So it's not the only reason. There must
plus we
be
can
Yes.
always go for ultrasound
It's
guided
net-
biopsy if
around
we're
this.
And
worried
if you
about
say,
the
if you
It's
say
in a
damage
tight
to the,
space.
if you say damage to the neurovascular bundle around, and that person shouldn't be doing the core biopsy at all because he or she is not competent. Nowadays, we've got very clear, good image guided systems. So there is
Exactly.
very little chance of damaging these structures. So what's the main reason that we don't do core biopsy?
Thyroid is an enclosed tight space.
Very good. And
Potential
Uh,
hematoma.
bleed- a
Hematoma,
bleed
if it
into-
happens, it can
yeah.
compress the trachea.
thyroid is very firmly wrapped around inside the pretracheal fascia. Let's say it starts to bleed, and it will definitely. What
tension
happens is
hematoma.
there is
Tension
a
hematoma.
big hollow tube inside, which is the trachea. The hematoma, rather than expanding outwards
Laryngeal spasm,
and
laryngeal edema.
inwards, and then causes compromise in the trachea.
Edema.
As a result, compromise of the airway. Assuming this patients, these are usually day cases. They come in, did the biopsy, and then goes home. On the way home, this happens. Patients ultimately is going to die. So that's why core biopsy is contraindicated for the thyroid. Right. So the next step would be incisional biopsy, subtotal hemithyroidectomy or subtotal thyroidectomy, depending on the cases. And then we can move on with the frozen section. We can move on to the total thyroidectomy afterwards. Right. So this is the compression symptoms, as we briefly talked about, stridor or dysphagia, malignancy, anaplastic, or cosmetic reasons. So when do you do surgery in hypothyroid patients? So let's say you've got a patient, hypothyroid patient, you're going to do elective surgery. When do you do surgery?
Once they have become euthyroid.
Once the patient is euthyroid, we'll give
How
them
do you know
IV
the patient is euthyroid?
levothyroxine, and
TSH is normal.
Monitor with
after
They're
TSH.
3 to 4
monitoring their
TSH.
TSH.
Very good. What we look at is the TSH. Once the TSH comes back to the normal range, that's fine. That's safe for you to proceed. What if it's an emergency?
So then we'll
We
give
can
them
use IV levothyroxine before
Yeah.
30 minutes. That's fine.
We either use IV T3 or T4, right, depending on the
IV.
severity. If it's very, very severe, what's the most severe form of hypothyroidism?
Mixed
Mixed
edema
edema
coma.
mixed
coma.
edema
Edema
coma.
coma.
Then
If
we'll
the
give them
patient-
T3, which is the
If-
active form.
If the patient's showing signs of mixed edema coma, then it's time to give IV T3. Otherwise, IV T4 is commonly used, and it's given as a induction dose and then followed by daily dose, usually IV, but you can give IM as well. Right. Correct for the liver, for the elective things, you give levothyroxine and monitor the TSH. Once TSH is normal, we can proceed with surgery. For the emergency, IV T4 is preferred. Once the patient's in mixed edema coma, then we will use the IV T3, that is liothyronine, and followed by the maintenance dose afterwards. Of course, if it's a hypothyroid station, then we need to talk about the complications of the hypothyroidism, which is fairly easy. Complications of hypothyroidism are usually the symptoms of the mixed edema coma, just not severe enough to be called a mixed edema coma. So give me a few symptoms.
Severe mental
dysfunction,
hypothermia,
hypothermia,
hyponatremia,
cardiac arrhythmias, especially bradycardia,
heart failure,
coagulation
hypothermia,
defect,
severe mental
hypoglycemia.
retardation, and end organ failure.
Right. So there are so many things that we can talk about, right? Mixed edema coma would be the ultimate complication. Altered mental status, hypothermia, bradycardia, hypertension, effusions, and heart failure came as a bundle of the organ failure. Next, the complications of thyroid surgery. Tell me a few.
it's immediate, early and late, immediate bleeding and the hypokalemia and early recurrent lymphocytosis and late thyroid insufficiency, parathyroid insufficiency and scar complication, hypertrophic scar.
Great. Whatever you talk about it, early, late, or delayed,
Intraoperative.
or you can do it intraoperative, post-operative, doesn't really matter. What you need to include is 1, bleeding, 2, damage to the strong structures, 3, infection, especially damage to the strong structures, particular structure for the
Recurrent
thyroid
laryngeal
surgery.
nerve.
Recurrent laryngeal nerve, parathyroids.
Very good. So we cannot finish the complications of the thyroid surgery without recurrent laryngeal nerve palsy, obviously. Right. So choose one and manage it. Regardless, we'll say, let's say bleeding, how are you going to manage the bleeding?
Well, if it's intraoperatively, we'll ligate, suture ligate. If it's post-operatively and the patient is developing tension hematoma, we'll open the sutures, first the skin, then the platysma. We'll drain the clots. We'll shift
So
the
where are you
patient
going to open the
immediately
sutures? On the
Then
ward?
and there.
to
ITU,
relieve
theatre?
compression effect of the tension hematoma
Wherever the
on
patient is.
larynx.
Bedside
Where
remote.
are you
Bedside.
going to open the sutures is my question. So
Bedside.
in the
Bedside.
ward, in the
Bedside,
ITU,
bedside,
theatre. Not on the
bedside.
bedside, wherever you find the patient. Right, if the patient is lying on the floor next to the toilet, you open it there. Right, if the patient's found in the corridor, you open it. If the patient's found in the ground floor shop, you open it there as well. So wherever you find the patient, you have to open it straight away, because otherwise that's going to cause the same thing as if you're taking the core biopsy of the thyroid hematoma, going to expand usually inwards and then causes compromise in the airway. Right, next, hypocalcemia. How are you going to manage that?
This
We'll give
is
the
Ectopic
Calcium
transient.
symptomatic.
replacement.
We can
calcium
use
gluconate, especially
oral
IV.
calcium.
If no symptoms, oral. If symptomatic,
Symptomatic
IV.
Very good.
calcium
Simple.
chloride.
If it's simple, no symptoms, you don't need to give IV. You just need to replace oral, and usually you can replace up to 4 grams per day. So 1 gram tablets 4 times a day, and then later on taper it. If the patient's having symptoms, then that's problematic. What symptoms are we talking about?
Schwastic sign, Trozo sign.
Perioral numbness.
Perioral numb.
So most of the time, those signs will become
Right though.
in the later stages. So starting with the perioral numbness or
Carpopedal spasm.
Carpopedal.
not yet. If the patient's having spasms, then you should be very, very careful about it.
Paresthesia.
Muscle
Tingling
cramps.
So
Muscle
the most
cramp.
common ones
Pins
are
and needle sensation.
sensations or the perioral numbness. So these are the start of the symptoms, and then it goes carpopedal spasms and more severe things. So Schuster's, tell me, how do you test the Schuster's sign?
Tapping
How do you
to
test
the
it?
angle of the mandible cause.
You tap the
look.
tragus and you see
Very good. You
twitching
tap on the
of
facial nerve, which exists
facial muscles.
around in front of the ear, around that area,
Yes.
and that's where the
You see the twitching
twitching
of
of
the
central muscles will happen. Right.
yeah.
Trousseau. How
You
do you
take
test the
the
Trousseau sign?
you take the
We
blood pressure
Inflate the BP cuff
inflate the PP
and
cuff to above systolic
when the systolic blood
level
pressure is
and
greater than 20
observe for
millimeter the normal, you notice a carpopedal spasm of the
Great. You increase the blood pressure usually about 10-20 millimeter mercury. Leave it there for
20 millimeters of mercury.
1 to 2 minutes. Yep. And many of the texts will say 20, but if the blood pressure is 160, I wouldn't leave it for like 180 compression for
Right.
a long time anyway. But anyway, so about, yes, theoretically, that's correct. About usually 10 to 20 millimeter mercury above, and then leave it for a few minutes. And then what you're going to see is the spasm of that. Well, you can, again, replicate that with the lower limb as well. Just above the ankle, you can taper around and then inflate the calf above the systolic pressure, wait for a few minutes, and then you can see the twitching of the ankle. So these are very late signs. So you must give IV calcium, usually is a calcium gluconate, or as a calcium chloride, you can give that as well. So which muscles are you worried about with the
laryngeal muscles?
laryngeal muscles.
why are you worried about the laryngeal muscles?
Laryngeal spasm
Laryngeal spasm
cause
cause
airway
to
compromise.
respiratory arrest.
Right, laryngeal spasm can
Laryngomalacia
lead to
due to
fatal
laryngeal
asphyxia. Fatal asphyxia leading to loss of airways. What other muscles would you be worried?
Posterior tricuspid.
Cardiac muscle.
Cardiac muscles. Yeah, the ones are the cardiac muscles. If you don't treat it aggressively, they're going to go into the VTs and the VFs, and then heart blocks, and then cardiac arrest. So coming back to the complications, so nerve complications. Recurrent
Damage to
laryngeal nerve
damage.
injury.
How are you going to manage it?
superior laryngeal nerve and then recurrent laryngeal nerve.
Unilateral
Laryngeal nerve
injury,
will lead to the
conservative
loss of
management.
pitch.
Bilateral
recurrent-
nerve injury, we can manage it tracheostomy and vocal cord plication.
Great.
Total.
So unilateral nerve damage doesn't necessarily need any of the special treatments. You can do conservative management. If it's a bilateral, sometimes the patient will end up with a stridor and the respiratory compromise. If that's the case, the patient may need, in the acute setting,
Reintubation,
followed by
tracheostomy.
Emergency tracheostomy.
followed by
Uh,
lateralization procedures, cord plications,
Vocal cord lateralization.
all of these things. Right. So let's quickly go through these ones. So complications, bleeding, hypocalcemia, and the voice change, for example, recurrent laryngeal nerve or the superior laryngeal nerve, right? This is rarely significant except in professional singers, because that's profession. And the wound infections could be thyroid deficiency in the late stage parathyroid insufficiency, atrophic of the keloid, wound problems. So what's the leading cause of hypocalcemia after thyroid surgery?
Hypoparathyroidism.
Right. Why does hypoparathyroidism result after thyroid surgery? That's my question.
Accidental removal of parathyroids.
Removal of
all
the
four
gland
of
is
them.
far less common than
Ischemia.
Binding of the inferior thyroid artery causes ischemia.
Very good. So the most common reason is the ischemic parathyroid glands leading to hypoparathyroidism, subsequent hypocalcemia. Right. So the management, we briefly talked about it. So bleeding, remove the skin, skip wherever the patient is. Unilateral nerve damage, conservative management. Bilateral, then the patient would need tracheostomy, vocal cord plication, and I think total laryngectomy, these are reserved for very, very severe patients and more than cancer patients. We don't do that anymore nowadays. Hypocalcemia, oral calcium 4 grams per day. If no symptoms, if symptomatic, give IV gluconate and closely monitor the patient. So this is the end of the station. And one thing I'd like to point out is whenever you study, do not just read through, try to memorize it. It doesn't work that way. Try to connect with what you already know. And that's how we human beings learn, and use that to your advantage as well. So that would be pretty much of it from my side. Do you have any questions?
I have a question. So once we start the patient on replacement therapy of any sort, be it thyroxine or anti-thyroid drugs, how long do we wait for elective surgery? 3 to 4 weeks for the drugs to make their action?
Depends. As we said, we usually monitor the TSH. Usually a few weeks. You're correct.
Mostly 2 weeks.
Yeah.
Okay. Thank you.
Great. Any other questions?
So
Great. Go on.
For if unprepared patient, we are concerned about mostly what complication?
What do you mean?
You asked me that we have emergency surgery, and we are mostly concerned about which complication.
If emergency surgery in a uncompliant, non-compliant patient, what will be your answer?
Myxedema coma.
Myxedema coma. That would be your dreadful complication, because normally it takes a bit of time for them to go into the myxedema coma. But if you do surgery, if you remember, one of the triggers is a stress event on the body, and the surgery itself is a huge stress on the body, and you are triggering the myxedema coma yourself if you're not really well prepared. Yes, I hope that. Thank you. All right. Great. I just saw the message from Freyden. So please feel free to text me afterwards if you want to know about more cardiac surgery in the UK. All right. Any other questions?
Thank you very much.
You are welcome. All right. If not, have a great weekend. We will see you next week, hopefully. Thank you. Bye-bye.
Thank you very much, sir.